Welcome to Public Health Matters, where we talk about matters in public health. I'm Jane Goodman, Public Health Network Strategist with the Division of Public Health and Community Services. And before we get started with our guest, I want to give you a little public health update. This week in COVID-19, we are at a green community level in Hillsborough County, which means we are at low risk for COVID-19. This is good news, but if you look at the New Hampshire map, which is coming right up here, we still do have some counties adjacent to us in Maine that are in medium risk. So we're not really out of the woods yet, so do take your precautions, wear your masks when you're indoors, and still continue to be aware of the COVID spread in our community. A reminder that there is a new booster available. It provides protection against the Omicron variant and the original strain of COVID-19. NHDHHS, the Department of Health and Human Services, recommends a booster 3 months after infection or your prior vaccination. So you can go get that shot at your local pharmacy, and they're readily available. So please take care of that as we enter the fall, the colder weather, and we're indoors more, and there's more of a chance for some spread. On the monkeypox front, what do we know? We have 24,203 cases in the United States. In New Hampshire, we have 28 reported cases. Monkeypox is spread through close or intimate contact, prolonged face-to-face contact, or through prolonged touching of infected fabrics such as bedding, towels, or clothing. Some of the symptoms of monkeypox include fever, chills, headache, sore throat, swollen lymph nodes, and exhaustion. And you can see up on that graphic what we're talking about there. There are some new criteria that have been released for vaccination. So we're going to put these up here, but persons who identify as gay, bisexual, queer, or other man who has sex with men, we call MSM, and believe they are at risk for monkeypox virus infection, including persons in a monogamous relationship who have a sex partner that is at a higher risk for monkeypox. So if you fall into that category, you can receive the Jynneos vaccine. Also, persons who report in the prior 14 days a known exposure to another person infected with monkeypox virus or contaminated objects. So if you're living in a household with someone who is tested positive for monkeypox, you should try to get the vaccine. And that's also the post-exposure vaccine should ideally occur within 4 days of an exposure to prevent disease. But vaccination can be up to 14 days after your exposure. So even if you miss that 4-day window, you can still get vaccinated up to 14 days later. And here is a map of where the Jynneos vaccine is available. We have many sites in the state, and you can see that the Convenient MD urgent care centers are taking walk-ins, so there's quite a list. And if you have any questions about monkeypox, the state has set up an email direct response, and that's monkeypox@dhhs.nh.gov. And it is my pleasure to introduce our guest for today, Dr. Gautami Rao. Welcome, Gautami.
Thank you, Jane.
And we are going to talk about cancer today and cancer prevention. And Dr. Rao, you've been in the community for a very long time, as we were just discussing before the show, as long as I have. So
Yes.
We're old timers here in Nashua and Greater Nashua. And so just tell me how long you have been here and tell us a little bit about your practice.
So I've been here nearly 30 years. Came here at the same time your husband did, you both did. And I've been at this practice for nearly all that time, except for a brief period of 4 years when I was at Dartmouth. But I still covered Nashua at that time. So 2023 will be 30 years.
Oh, and so you are an oncologist, is that the correct, or do we say oncologist and hematologist?
So I actually have 3 specialties
Okay.
that are related to each other: oncology, hematology, and palliative care.
Okay.
So I do all of those.
All right. And so you've been here almost 30 years. You have a lot of experience. Do you have any area within oncology and hematology that you tend to see more patients in or specialize in?
I've kind of drifted into it by need. I do a lot of breast cancer.
A lot of
I
breast
think more than 50% of my daily work is breast cancer.
Oh, wow.
Yeah.
So there's been a shift.
Yes.
Okay. So we thought that because September is a month that recognizes a lot of different cancer awarenesses, there'd be a good time. We have Childhood Cancer Awareness Month, Ovarian Cancer, Prostate Cancer Awareness Month, and we also have Healthy Aging Month. And not to make too much, but as you age, you're probably more at risk
For cancer.
developing cancer.
Right.
So I didn't make an incorrect assumption.
No, you did not.
So we thought, all of these things we could talk about some cancer prevention. And what we can do to minimize our risks. And there's many different types of cancer, so we'll just kind of go
with
where
the
we go.
Most common ones, maybe.
Yeah, and we might as well start with breast cancer.
Right. So
so-
before I do that,
Yes.
I just want to explain that, cancer is a disease of aging. The longer we live, I say this to most people, if you live to 150 years, most of us are probably going to die of cancer. But of course, that's not going to happen. So cancer happens because immune surveillance, our body's ability to prevent cells from changing, is lost. And it's lost because of getting older, it's lost because of wear and tear, but it's also lost because of behavior or genes or anything, many other factors, some of which we know and some of which we don't know. So I just want to start with two basic principles. Our body is a wonderful organ, and from the day we're born, we have two sets of genes that actually watch and stop cancer from forming. One is called the proto-oncogene. It's like the accelerator. If something happens to that gene, say there are two genes and one is abnormal, the accelerator gene is accelerated, that can lead to cancer formation because the cells change, the DNA changes. The other is called like a brake. It's called the tumor suppressor gene. And what these genes do is they're constantly finding a way to stop genes from changing, like a brake. They try to put the brake on it. And if something goes wrong with the brake mechanism, then cancer forms.
Okay.
And we can influence these in some instances, and sometimes we cannot. But that is the fundamental. Every cancer is genetic, whether it's inherited or acquired.
Oh, that's very interesting. So some things we can't really control.
Some things we cannot, yes.
Okay. But we can do some things, I hope.
Oh, lots of things.
Okay, good. Otherwise, we're going to have to end the show.
Yeah.
So are there certain risk factors for breast cancer, for example?
The most common risk factor is the female sex. Estrogen is the driving force behind most breast cancers. And so even when women are menopausal, estrogen is still being made in the fat tissue and in the adrenal glands in the body. So the amount of estrogen may be less, but actually breast cancer is more common in women in their 60s and 70s. So estrogen and being a woman is the most common risk factor. And that's why there's a difference. For the risk of breast cancer in women is 1 in 8. In men, it's 1 in 1,000 without the gene. But then, yes, there's a genetic risk, there's lifestyle risk. And so mostly those are the common causes. Sometimes when people are exposed to radiation at a young age, say in their 20s, if they get radiated to the chest for, say, a childhood cancer, then they might be at a higher risk for breast cancer.
Okay.
So most of the risk, though, is just the female sex.
Okay.
And then there are littler, softer risk factors. How old was one when they got pregnant? How long did they menstruate? So technically, women like nuns who don't break their reproductive cycle with pregnancies tend to have a higher risk of breast cancer.
Wow.
So
Okay.
it's so those little things. If someone takes hormone replacement for a long time, especially estrogen, they might be at a higher risk. But fertility medications and current oral contraceptives are not considered high risk.
Okay. So you mentioned something like giving birth. Does it breaks that cycle?
Yes.
So that is a protective factor?
Yes. So actually, the more number of pregnancies you have, there's a slight, but these are not, I mean, this is not the only thing that's going to decrease the risk, but that is a plus. So if someone who has had 4 pregnancies, head to head may have a smaller risk than someone who had no pregnancies.
And so, so as far as breast cancer, you mentioned briefly that there are some lifestyle things you can do.
Yes.
And what would those be?
And this is what everybody makes fun of me at work. I call this my soapbox. You know, mammograms help, going to the doctor and getting breast exams help. But there's one thing that we can all do, it's completely free of cost almost, and that is to be as physically fit as possible. So lifestyle, you know, obesity, a diet that's not, you know, that's kind of rich in calories and processed foods, but physical activity, getting the heart rate up. So there's enough data that says 3 to 6 hours of exercise a week can decrease the risk of recurrence of breast cancer in someone who's had breast cancer. But exercise on the whole is one of the best protectants against not only breast but many cancers.
Oh, okay. 3 to 6 hours a week.
Ideally, even if it's 30 minutes a day of getting your heart rate up, but it is the consistency that matters. It cannot be, you know, 2 days and then I'm done.
Right.
It has to be every day, as
Okay.
much as possible.
And you're making me think, how am I going to get my exercise in today?
And maintaining weight.
Yeah.
So that's so important.
Yeah, so that's good advice for everyone. And then you mentioned mammograms. So I have these listed out of like prevention, but I think as we go through each type, maybe that's good. Like for screenings, when should a woman get her first mammogram, and then subsequent to that?
So average Caucasian woman, mostly in the Western countries, mammograms start, at least in the United States, we start at 40. Now there are some European countries in Canada where they start at 50, and they might start at 40 and do it every other year. But here in the United States, it's 40. There are differences and different recommendations. If there is a family member who had breast cancer before the age of 50 or 45, the rule of thumb is 10 years before the mother, sister, or child. So if somebody had breast cancer at 45, their daughter would probably have their first mammogram at 35.
Okay.
So if there's a genetic risk, then the dates change. But for the average woman, it's 40 annually until maybe 75, maybe now it's 85. The concern is, and this may sound a little harsh, but if somebody is expected not to live 2 or 3 years and they're at the end of their life, then I'm not sure doing a mammogram is to their best interest because they may not be able to go through the treatment.
Okay.
Right? So we used to say stop at 75 and then reassess on an individual basis. But now in seeing how much the population is so healthy even in their 80s, most of us will say maybe 80 or 85, but then make an assumption based on their functional status.
Okay.
If somebody is flying a plane at 92, that woman should have a mammogram.
Right.
You know, so
But
yeah,
yeah.
exactly.
Point taken. Like it really makes sense because at one point, like if you can't handle the treatment, why do you even need to find out?
Find out, yes.
And that often happens with a lot of chronic diseases at that point. Like you don't need to be tested for one other thing because
Exactly.
you're dealing with other issues. So, so we want to get in there at age 40.
And every year.
And every year
At least in the
subsequent to
United
that.
States, it's every year.
Now you mentioned white Caucasian, but what about, is there a higher rate of breast cancer in the African American
Yes.
community? And that's something like, you know, we're really talking about health equity and how do we encourage a lot of these communities to make sure they're getting their preventive screenings.
And the same recommendations go for the African American population too. They start at 40. And I don't think we're doing anything different for breast cancer in African American population, but for prostate, we start younger in the men.
Okay.
So going back to that, we can come back to that later, but for African American women, we'd still start at 40, and their family history drives the bus. So if there's a family history of, say, multiple breast cancers, then those women would have to maybe start at a different age.
Okay, but do you see a higher prevalence among African Americans?
Yes, and maybe more advanced cancers
Okay.
sometimes, because sometimes it could be because they're not getting access to
They're getting the
healthcare.
screening. Okay, so we want to remind everyone to get that screening at age 40. So you mentioned prostate cancer, that's on my list. So let's just keep going. Some of the risk factors again. In fact, I just had this conversation with my husband because we were talking about somebody. And I said, does everyone get prostate cancer? Like, because I know so many men
Right.
who have. So again, it's the aging thing.
Right, and that is actually true. If you go and look at the autopsy series after, when we do an autopsy after death, by the age of 80, 80% of men will have prostate cancer in their prostates. But that is a cancer of aging. We want to take care of the prostate cancers that causes premature morbidity and death.
Okay.
So African American men, 45. Caucasians, men, 50, to start talking to their doctor about checking. So this is a gray area. There's fairly strong feeling. The urologists and the oncologists and the radiation oncologists will say, get a PSA. The family practitioners and the internists would say, no, not everybody needs a PSA. We do a prostate exam, the prostate is fine. We don't have to do a PSA. It's each person's call. Because there is a concern. If we do a test and it's abnormal, not every abnormal test leads to cancer. So there's the morbidity of having a biopsy and complications.
Right.
So this is somewhat controversial, but when we see a lot, on the oncologist side, we see people with bad prostate cancer. So for us, the concern always is, why couldn't this have been picked up earlier? So I think this is one place where a man with a family history of prostate cancer in someone less than age of 65, they have to have their PSA checked.
Okay.
I would say starting at 50. But if somebody has a parent or a family member with prostate cancer at 90, then it's a toss-up. Do they want to just have their prostates examined, or do they want a PSA? And it's your sense of safety. If somebody is physically fit and they're doing great and they have a wonderful diet and their prostate is normal, they don't need a PSA.
Right, right. So again, I keep hearing a theme. A lot of this is
Yes.
genetics, so you really want to know your family history, whether.
Exactly.
And when we look at our family history, are we looking at our direct parents, or do we look at aunts and uncles? Like, how far do we need to go to really understand?
I would say both. So
okay.
the most important is the first generation. I mean, first degree. And that is parent, sibling, and child.
Okay.
That is the highest risk. So if there are, say, multiple siblings with prostate cancer, or two parents with similar cancer, then the risk in the child is much higher. But in the genetic basis, the second degree relatives matter too. So the siblings of parents, grandparents, and the children of your cousins, aunts and uncles. So that comes into play, say, for many of the genetic cancers. Then you need to know more, second and third degree.
Okay. But for most sibling, parent,
child.
Okay. It's a lot. I mean, it's a lot to know, and it's a lot to be aware of, but that's, the good thing is a lot of us do know that
Right.
family history.
And I think now with Ancestry and all of that, Ancestry and
Oh,
me
the
and
23andMe.
and I'm sorry, yes, all
Yeah,
of that.
Ancestry.com, right? You can
So
check
people
your
are
genetic
finding out
markers.
more.
Yeah, that's an interesting thing. So especially if you don't know your origins, or if you, that may be a way to trace some of that. I have so many questions because there's so many different things. What about skin cancer?
Most common cancer on Earth, especially basal cell and squamous cell cancers, but they're really not considered worrisome because they are local cancers. They can be removed, they can be monitored. They don't usually cause death.
Okay.
So melanoma, which is the cancer that comes from a mole, is really also related to sun damage, and they have to be watched for. So if somebody has, say, more than 50 moles, or they're fair-skinned, and or the red hair, or the blue, green, or hazel eyes, or a family history of melanoma,
Right.
they have to have their skin checked at least once a year by a dermatologist.
Okay.
The scrutiny would be very close. Ultraviolet light will be used, and that's very important because melanomas can be fatal if not caught early, but they're potentially curable.
Okay.
So even though they're the most common cancers, they don't cause the most mortality.
Okay, interesting. And I know, so it's my pitch because I'm a public health person, sun exposure.
Yes.
I mean, if we want to prevent this, because even if they don't cause mortality, it's no fun to have them cut off.
Right.
And, it's just no fun. And oftentimes it can be near the face and all of those things. So
Right.
pitch
Avoid
for, yeah, stay out of the sun, stay in the shade, use sunscreen.
Exactly.
And just really make those good decisions as far as the heat goes. Okay, let's see. Oh, wow. I'm looking at my list just to make sure I hit all the big ones. Well, colon cancer is another one because, that affects both men and women.
Actually, colon cancer is becoming the most common cancer in both sexes in all over the world.
Oh, really?
So the United States has recently changed its screening protocols. They're now recommending 45 years of age
Okay.
to start screening, not 50. And again, caught early, very curable. And it has got a fairly significant genetic basis. So there are some preventive aspects. Colonoscopy, no doubt, has improved the outcome, but we're also having more colon cancers because of diet and lifestyle changes and the fact that we're looking and the population is getting older. So there are many reasons why, but no shortcut to exercise, watching your diet, lots of roughage, less processed meats and sugars, as little alcohol as possible, and weight.
Wow, they all cross over. All of these things you're saying are things we talk about for heart disease, and we talk about for just about everything, diabetes, all of these things we talk about in chronic disease. They're the same as in cancer.
Cancer, exactly.
So, the importance of that exercise and the clean diet, I call it the clean diet.
Right. So actually I have some a figure here that I found fascinating. So it said, and this was from the 2020 American Cancer Society's booklet, said 42% of cancers that happen currently are preventable.
Wow.
Of which 19% is from smoking and 18% is from exercise, obesity, alcohol, and diet.
Wow.
And then the rest is sun avoidance.
So that's wow. So we've kind of hit them, if we think about like all those preventive things, like that's a huge number of preventable cancers. So it's a good topic we chose today.
Yes.
So you mentioned smoking, so that brings me to lung cancer. I'm a big advocate of a non-smoking environment. I wish we could get rid of them altogether.
Yeah, absolutely.
Because it just causes so many issues. But lung cancer is, I think, the leading
cause of death.
Leading cause of death.
And men, I think, or yes, I think it is. But what's fascinating is this, the other thing. I have 15 cancers that are caused by smoking.
Oh, why don't you read down the list?
I will.
So we can really prove to people that they need to quit smoking.
So lung, of course, everybody knows about it, but the larynx, the voice box, the throat, the kidney, the bladder, the ureter, the nasal cavity, the oral cavity, pancreas, penis, stomach, mesothelioma, acute myeloid leukemia, kidney, esophagus, cervix, and colorectal.
All of those?
All of those are caused. There's a risk factor with lung cancer.
I mean, some of them didn't surprise me because you went from here to here, but then you really just went on.
So pancreatic cancer, actually, cervical cancer.
Wow.
Pancreatic is very hard to find. You don't really find it unless it's later on. But cervical cancer, pap smears.
Right.
And so absolutely don't smoke and get a pap smear.
Yeah.
Simple.
So all those preventive measures that you need to do, your preventive screenings, why we, especially as you get into your, let's just say 40s, that's when you're really going to start seeing that primary care physician, internist, or family practice, and just make sure that you do those screenings on the recommended basis so that you stay healthy.
And some might say, I exercise and I did all that and I still got cancer. But the thing is, there are two things in their favor. They might have had cancer earlier if they didn't do it. And the other is it makes them get through cancer treatment better if they did and kept themselves physically fit. So there's one more new recommendation for lung cancer screening, and that is anybody who has smoked what we call 30-pack years, which is either 2 packs a day for 15 years or 1 pack a day for 30 years, and have quit, but within 15 years can get a lung CT scan every year from the age of 55 to 80, depending on which agency is certifying it, but that's what the American Society of Oncology says. And it's a low-dose CAT scan, because that's the other thing. Exposure to X-rays is a risk factor for breast cancer or cancers, but more in the younger population.
Sure.
So when we are in our 60s and 70s, our risk of cancer from an X-ray is not that high.
Okay.
So getting those X-rays can catch lung cancers much earlier and actually improve the curability.
So yeah, I'm really glad you brought that up. I had formerly worked for Breathe New Hampshire, and that was something we were pushing out a lot, was that low-dose CT scan to make sure, if you did have that history of smoking. So there's a lot to remember here. But it's great information and really important information. So we're just going to remind people to exercise, eat right, the same things we're on our soapbox. I'm right up there with you, though.
Thank you.
Wear your sunscreen, stay out of the sun. The exercise seems really key, like you said, not only for cancer, but for so many other things. So last question, what advice would you give someone who's awaiting treatment for cancer, since that's kind of a scary time?
Extremely scary. And I tell them, get 1 or 2 people in the family or friends to be your support. And when I say support, truly somebody you can say, hey, come and clean my bathroom, or come and take care of my kitchen or cook dinner for me. Always take someone with you to meetings with physicians, because it's good to have a second pair of ears. And divide up the problem into little problems. If somebody goes to see an oncologist and they hear all of this, chemotherapy, surgery, CAT scans, second opinions, support group, all of it gets overwhelming. So just say, let's get the testing done first. Then based on that, we'll say what the next treatments are. And if surgery is going to come later, we'll worry about surgery later, but let's take this in little parts.
Bite it off in small pieces. And
no harm in asking for help. There are professional people there who can help with helping you cope with it. And there's no harm in saying, I'm frightened. I think that's what it is. Take someone you trust and divide up the problem into little problems.
Okay. Great advice, and thank you. Thank you so much for taking time out of your busy schedule to educate the community on this very critical, illness that can happen, but also you've given us a little bit of hope too, that not everything is fatal.
Right.
Although can be scary, there are one step at a time.
And many cancers are now treatable and curable.
Yeah, which is really great news.
Right.
So thank you.
Thank you, Jane.
And I want to thank you all for joining us and remind you that we do have a clinic open at Nashua Public Health on 18 Mulberry Street. We have immunization clinics and lead testing clinics, and we also have a sexual wellness clinic, which is open on Thursdays from 3 to 6 p.m. And I want to also remind you all to get fully vaccinated, whether that's your COVID booster or your flu shot, because we're entering flu season, folks. So stay healthy, stay well, and we'll see you next time.